MD Anakul Milton. Dr. Milton is MBBS DA anesthesiology. He has completed both FIPP and CIPS in one shot, which is in itself a great achievement. Dr. Milton is EDPM and FIPM. He is a fellow ULAR in rheumatology and MSK ultrasonography. Dr. Milton is Director and Chief Consultant, Pain Medicine at Spring Hill Hospital Limited, Faridpur, Bangladesh. Dr. Milton is a faculty at Daradia Pain Hospital, Kolkata. He is a board member of World Pain Academy, UK. He has a list of awards against his name. In 2020, he was awarded the Young Pain Physician Award by BSA CCPP. In 2021, the Pain Ambassador Award at ICRA. 2022 Apex Healthcare Excellency Award at Delhi, India. 2022 Young Pain Organizer Award at SARBS 2022. He has numerous publications, 14 international and national publications to his name. So it's a great privilege for us, Dr. Milton, to have you with us. I would like to invite Dr. Milton to now take the stage and start off.
Thank you, my dear friend, and my dearest brother. Actually, Dr. Javed is very close friend of when actually both are in Daradia 1-year fellowship. So thank you, Dr. Javed, and he's a very promising pain physician in Bangalore, and also he set a very nice and very good clinic setup in Bangalore, as well as he did a lot of online and offline different type of workshop, including the hands-on training in Bangalore. And definitely it is a very promising things in our pain medicine, because we need a lot of pain medicine specialists in our society, because we have a lot of patient, but the service is not up to date. Right now, those are servicing, or those are actually serve this area. So thank you, Dr. Javed, for inviting me. And it is great privilege to me to talk in your big platform.
Thank you, Dr. Milton. Your slides are visible.
Thank you. So today we will discuss regarding the some cervical intervention pathology, as well as the ultrasound in actually in previously like 3 to 4 years back. Actually, most of the intervention we did in CM guided procedure, but right now actually we shift a lot. And in cervical, there are a lot of blood vessels, a lot of important nerve is there. So when actually we need to intervene under fluoroscopy, so there is some difficulties or some chance of uh, injury or adverse effect that may happen to the patient, even life-threatening. So it is a very good things that if you use the ultrasound in your practice, so it change your dimension. So far, actually, we right now we do a lot of ultrasound in our any side of the body, because we know that ultrasonography is a very good things when actually you do over the patient, because you can manipulate these things over this patient lively. So you can see the everything like arterial flow, you can see the nerve, you can see the important structure, you can see the pinpoint needle traveling and the end point of the needle. So all things are very important for a pain physician when actually he did any kind of intervention in his setup. So today we will discuss like the most common symptoms, like the facet symptoms, cervical facet, cervical radicular pain, as well as some occipital neuralgia, as well as Another things, that is the sympathetically mediated pain is originated by the upper limb and the neck. Through it goes through the stellate ganglion. So those few topics actually we will discuss, and we will try to understand these things easily. And if there is any kind of questions, I will happy to answer you if you have any kind of questions. So facet symptoms. So we know that actually previously when actually we our pain specialty it's not developed so much. So that time actually facet symptoms are not so much well treated. So but if we see that nowadays the facet joint is the most common pain symptoms, especially in the cervical and lumbar area. So what is the presentation of the facet symptoms? So usually patient have no neurological symptoms. Only patient have a either unilateral or bilateral neck pain, and it is mostly elevated by uh, flexion, especially the extension and rotation. Sorry, I am suffering in common cold. So, so when actually, if we see the upper cervical area, so that time actually patient need to rotation as well as the flexion. But when actually we elicit the pain in the lower cervical, that time it is specially changes in extension as well as the rotation. Okay. And we can do another few examination like injection test, like you can do the palpation over the facet joint. So if any facet joint are painful, that causes the tender or highly tender when actually we press over the facet joint area. So these are the most common findings actually when we find out the facet pain in the cervical area. So there is we can do some X-ray, CT scan, or MRI, but every intervention have not a very clean-cut idea that this patient is suffering from the cervical facet joint symptoms. It is mostly history-based, as well as if you have a doubt, then you can plan for the diagnostic block to understand the pain generator. Okay, but there is no clean cut or like gold standard imaging system that give you the very quiet idea to this is the facet joint pain. Now come to the anatomy. So this is very important part. What actually I feel that every pain physician have to know the anatomy very clearly, very clearly. Without a good anatomical idea, actually your intervention, your ultrasonography, and your uh, like fluoroscopy is not completed. Okay, so I will discuss little bit about the anatomy. So cervical facet joint, actually they are the diarthrial joint, and it is formed by the superior articular process of one vertebra and inferior articular process of the another vertebra. So in lumbar area, their placement is a very lateral and posteriorly. But here, the cervical facet, they actually like 45-degree angle towards the posterior side. So this is the actual transverse plane. If you consider in the transverse plane, so it is like 45-degree. So this is the changing of the articulation. Like this is the facet joint. So this is the transverse process. If you see, so facet joint like this. So it makes the 45-degree within the transverse plane. And another one things, actually cervical facet previously we do intervention, but right now there is no recommendation of facet joint injection. Okay. And cervical facet joint is a solely synovial joint. And another very important things, a lot of actually mechanoreceptor and the free nerve ending over the synovial membrane area. And within the synovial membrane, we can see there is the adipose tissue and some fibrous tissue. Actually, they make a manifold of the synovial membrane. And actually, if there is any kind of any kind of pain or any kind of pressure or any kind of changes of the synovial articulation, it may be the whiplash injury, it may be the age-related changes. So it causes the irritation of this synovial membrane, especially the nociceptor. Those are actually very much sensitive to carry the pain. Okay, so if we see the innervation, so actually it is innervated by the articular branch, which is derived from the middle branch of the cervical dorsal rami, and especially actually all the dorsal rami, most of the dorsal rami are passes at the west part of the articular pillar, but except there is two. So one is the cervical 2 and 3. That's been this facet joint actually supplied by the single nerve, that is the third occipital nerve. This is very important in your exam. This is the third occipital nerve. This is actually innervated the cervical 2 and 3 joint, and this nerve is lies just 1 to 2 millimeter above this facet joint. And another is the exception, that is the cervical 7. In the cervical 7, it is very close to the upper part of the facet. So most of the I will try to annotate it. So most of the facet joint, they are like in the west part of the articular pillar. This is the articular pillar, you know that this is the articular pillar. But in the cervical 7, it lies mostly in the upper part. Okay, so this is the main differentiation from the other part. And another is the cervical 2 and cervical 3. So here actually the facet joint, so over the facet joint you can see the third occipital nerve. So this, so all typical are like this cervical 3 to cervical 6, and cervical 7, it lies little bit, this is the west part, little bit above from the west part, and in the cervical 2 3 it is lies over the facet joint. This is the main changes of anatomy in the facet joint innervation area. So almost I will discuss these things. So here actually the if we see that in the cervical third cervical dorsal rami, it have a two branches. One is the medial branch, one is the superficial branch. So superficial branch is known as the third occipital nerve. If you see the deep branch, so it is around the C3 articular pillar, and it gives supply to the C3 and C4 branches. So here you can see this gives actually innervation to the C3 and C4 facet joint. One is come from above and another is come from this area. So every facet joint have a dual innervation except the one, that is the cervical 2 and 3. Most of the cervical median branch that runs at the west part of the articular pillar, except the two, cervical 2 and 3, it is supplied by the third occipital nerve. So it is lies just over the joint area, and cervical 7, it is very closer to the superior articular process, and it is very closer to the foramen also. When actually you go for intervention, so it lies this area. So you know that this is the area for nerve exit. So here it's very close to the actually foramen. Okay, so you have to very cautious when actually you do cervical 7 facet joint facet median branch innervation. So, now, already I have discussed that there is no gold standard technique or gold standard imaging that give you the very good idea about the concrete diagnosis of the facet joint pain. So what we need to the diagnostic block. So for diagnostic block, always we do like median branch is our main target. So before doing RF or before doing any kind of other intervention, we can do the diagnostic block if patient have give the idea like more than 50% or 70% pain gone, that gives the positive regarding the diagnostic block. So it is a very important things. If you have any confusion to diagnosis, so you can do like a diagnostic block to the patient. So that gives a very good idea. So we can do with the lignocaine, or we can do with the help of the bupivacaine also. So how you should start your scan? So everyone just concentrate this part, because ultrasonography is a very important part, especially when actually you go for cervical area. What is the area you have to start? So first, patient should be lateral position. Patient should be lateral position. So after that, patient should be extend also. These are the two things. So after that, you have to palpate. Just posterior to the auricle, you can find out the mastoid process. Okay. So you to palpate this area. So over the mastoid process, you have to place your one probe. Okay. So when actually you just place your on probe, you can see the few things. What are the few things? One is your mastoid process. Another, you can see this is the first vertebra of the cervical area. So you can see the transverse process of the cervical one vertebra. Okay. So little bit down, you can see the big, very big, like very big uh, bones, cervical, second cervical, and it have a very big lamina spinous process. If you see the wall, the spinous process, only this one is the very big. Why very big? Because like four, like 8 muscle are just originated or inner or attached to this area. So this is very important part. Okay, because this area is very big, because a lot of muscle that are actually attached to this area. So little bit down you have to come. After that you have to come little bit posterior. So that then you can see this area. So this area means you can see this transverse process. Sorry, this lamina of the first cervical, and you can see also the lamina of the second cervical. So when actually see the broad area, this is actually the C2. Okay, so then you have to find out these elevated as well as the hill and valley part. That's been the hill as well as the valley part. So you can see these things also in, if you come little bit posterior, you can see the a lot of downwards uh like up and downs you can see also, but this is most superficial and these are the little bit down. So you have to like if you see, if you over the pillar or there's been the facet joint, you can see this is just within the 1 to 2 centimeter within the skin, you can see. But if you little bit posterior, little bit posterior, then you can see, but this is discrete, and you can see like this, and this is mostly the deep area. So this is the differentiation, how actually find out the facet joint from the other structure. Okay, so you have to start over the mastoid process, then you should scan this area, so little bit down and little bit posterior, then you can find little so much. If you come little bit posterior, then you can find out this area. Okay, then when actually you have placed your probe, always one important things, when actually the scalp is down or scalp is end, and here you can see this is the first cervical vertebra. So just in this area, the vertebral artery is exposed, because we know that the vertebral artery is entered through the foramen transversum within the cervical 6 or cervical 5 area. Most of the time the cervical 6. So it comes through this area. So after that it exposed and it comes to the within the skull. So here is exposed area. So if you see with the 2D mode, you can see only the black area. But when actually you give the Doppler just at the end of the mastoid process and just beginning of the first and second cervical vertebra, you can see there is the very echogenic structure, and it gives the idea this is actually the uh, vertebral artery. So sometimes many people, they have no very good quality of machine, including the Doppler. So this is very difficult to identify, and sometimes you can injury to the vertebral artery when actually you do the intervention. So and patient may die immediately. So you if when actually you plan for do any kind of ultrasound over the cervical area, you need a very good quality of machine, including the Doppler sonography. Okay. And another one things, why cervical facet joint intervention now abandoned from the part of our intervention. So this is a very important things, and this is a very good. I will try to. Hopefully, my screen is zoomed. You can see this is the facet joint. This is the one. This is the one. So you can see this is the facet joint. So anterior to the facet joint, you can see this is the actually foramen. So from this foramen, actually the nerve come through this area. And another is, this is the foramen transversum, and through this area, the the vertebral artery runs. So if you inject through the facet joint, if you missed or if you throw a little bit more, so it goes through the facet joint and it may hit to the nerve, or it may hit to the vertebral artery. So what happens? Patient may die immediately. So it should be keep your mind, and it should be always thinking before doing any kind of intervention in the cervical area, because this is very sensitive area and a lot of vascular structure that are directly communicated with the brain. So if you give any kind of, like even local anesthesia, if you give little bit more, so it causes the seizure immediately, and patient may die, or patient may any kind of permanent or transient injury uh, during the procedure. So always keep cool, always try to um, just make your hand uh, very sharp, as well as your thinking, as well as your vision, and as well as that your knowledge should be sharp. Okay, now come to the very important things. That is the I have already talked little bit of the third occipital nerve, because it is just above This is the cervical 2 and this is the cervical 3. So this is the joint, cervical 2-3 joint. So above 1 millimeter above, we can see this is the third occipital nerve. Okay, so we can come through in plane or out of plane technique. If you come in plane technique, that you come like this, or if you can come like this is out of plane. But what I request to you, if you are beginner, so then you better to go the in plane technique. If you have a lot of experience of ultrasound guided intervention, then you can plan for the out of plane technique also. Now come to the little bit down. So now we have started from the mustard process, a little bit down. So we can see the first cervical 2 and 3. So after that, we have to come little bit down. This is the cervical 3 and 4. This is the 4, 5. This is the 5 and 6, and little bit down. So suppose patient is suffering from cervical 4 or 5, 4 and 5 facet joint. This is 2, 3, 4, and this is 5. So which facet joint? This facet joint patient are suffering. So what is the intervention, or what should be the target in your intervention? So because we know that one facet joint is innervated by 2 nerve. So one come from the cervical 4, okay, and another come from the cervical 5 area. So we have to intervene, or we have to block 2 area. Otherwise, it's not completed. So one is this area and another is this area. Okay. So one median nerve is there and another median nerve is there. Okay. So this is the cervical 4 median nerve and this is the cervical 5 median nerve. That means it is correspond to the facet joint, just upper and lower. This is very easy. But only if you do the only one facet joint, this is innervated by the third occipital nerve. It is the exception in our body. Okay. So other than the every facet have a dual intervention. Now, when actually we scan in long axis, so that is identify your target area. It should be in the, it should keep in the middle portion of the of your screen. So after that, you have to go for the short axis view. When actually you go for the short axis view, that time you should come from posterior to anterior. So when actually you come, you can see the few things. This is very important. The first things you can see, this is the articular pillar, most prominent area and most broad area. So after that, you can see the sharp decline. This is the lamina, and the end of the lamina, you can see the spinous process. Okay. So if you come little bit anterior, so you can see the small part of the one bones. This is the tubercle. This is the tubercle of the transverse process. This is the posterior tubercle, and you can see the another bones. This is the anterior tubercle. Okay. So if you see where is actually the nerve, so I will annotate these things. So this is the articular pillar. Above it, you can see this is the median branch. That's mean the facet joint is innervated by the median branch. This is the median branch. So after that, you can see the one elevation and very small elevation. This is actually the posterior tubercle. Okay. So when actually we need to innervate, intervene the like a nerve root, that time actually we need to come our needle to this area. And here actually the nerve root. So this is the median branch and this is the nerve root. So when actually we go for the intervention, so that time in medial branch, we have to come this area when we have to stop. And when actually we have to come to the nerve root intervention, so that time actually we have to come just posterior tubercle, and here should be stop, not cross the posterior tubercle, because here is a very important structure, especially some radicular artery, feeding artery. So if you little bit more inside there, so may injury the nerve, and sometimes it may be suddenly spasm and to decrease the blood circulation to this area also. Okay, so these two areas are very important in our intervention and in our when actually we do the ultrasono guided intervention. So definitely remember these things. And another one important muscle that is covered the articular pillar, you can see this is actually the semi-spinalis capitis. And semi-spinalis capitis, and every muscle is covered by the very thin layer of the fascia. So in when actually we reach very closer, just a minute, anyhow it is closed. Please give me a minute. Okay, see, this is the articular pillar, and above there is the muscle. So this muscle is known as the semi-spinalis capitis, and it is in just insertion at the posterior tubercle area. Okay, so when actually we come just crossing the semi-spinalis capitis, we have to, when actually very closer to this articular pillar, you have to pin rolling movement. When actually you go for the pin rolling movement, you can actually cross the fascia that is actually covered by the uh, semi-spinalis capitis muscle. So when actually you cross this area, so that time actually you have very closer to the articular pillar, because the nerve are actually lies just under the semi-spinalis capitis muscle and just over the articular pillar. So you have to cross the muscle fully. But if you are not go for the pin rolling movement, that time, most of the time, your injection within the fascia. Okay. So if you go for the pin rolling movement, that time actually you cross the fascia and you can give very
Okay.
nice injection under this area. Okay. Uh, Now the procedure actually here actually we have to travel not a so much length, so we need to the like a 2 or 2.5-inch needle. It should be the 22 gauge up to 25 gauges, and you can use the lignocaine for blocking of the needle, blocking of the median branch. So if you see the median branch, how much volume? So traditionally, actually C3 to C6, those are the most typical area. So here actually we need to only the 0.3 ml. But actually when you go for the third occipital nerve, that's mean the first one, that time actually we need to the 0.9 ml of lignocaine for diagnostic block, and for the cervical 6 it's double, like in 0.3 it needs the 0.6 in cervical 7, because these are the atypical. So that time actually we need to the little bit more local anesthesia to diagnose the to complete our diagnosis. Now if we see what is the recommendation from the WIP. So if we see the recommendation, so cervical facet joint pain, so here actually we can go for the repeated injection with local anesthesia, with or without the corticosteroid. It is weak recommendation in 2008, 18, and in cervical facet joint pain, radio frequency, it gives also the weak. In cervicogenic pain, it gives like the very weak when actually we do the radio frequency of the medial branch dorsal rami. And in the whiplash associated injury, because we know that in the developed country, they in their road, when actually the vehicles are running, they have a very high speed, like 100, 120, 140, even 160 also. So whiplash injury is very common in their country, and also in whiplash injury, the radio frequency is a very advanced treatment or advanced and very good recommendation to the patient. So this is all about your my first presentation of facet. So after that, we will discuss. I'll request to mute yourself. The second topics, that is the selective cervical nerve root block, because we know that the most of the recommendation they give the cervical epidural rather than the selective nerve root. But like patient have a very clean cut nerve, disc herniation, particularly foraminal or extraforaminal area. If you see in MRI, then you can plan the selective cervical nerve root intervention, but it should be in your expert hand. Otherwise, it is very, very dangerous thing to the patient. So in even WIP, even others organization, they actually give them uh, very restricted about this intervention. They give the more recommendation to the cervical epidural, but most commonly the cervical epidural, it is covered the medial part, not covered the like far foraminal or the extraforaminal part. Okay, so patient present with the sharp shooting, burning, tingling like presentation to the arm, elbow, forearm, even in the hand. So we know that what is the area actually it is supply. If it is come to the thumb, so it is the cervical 6. If it is coming to the middle finger, it is 7. And if it is come to the little finger, it is the cervical 8. So these are the common presentation to our okay. Now, if we see the background, most of the 80% patient, they have a very acute presentation with the cervical facet. So after 6 to 8 weeks of exercise, medication, lifestyle changes, co-analgesia, so they actually come to back in the normal life. But rest of the 20%, they need the intervention like the epidural or the selective nerve root block. Okay, so now come to the little bit of anatomy. So if you see the anatomy, so actually cervical, we know that the cervical vertebra, and within the vertebra there is the foramen, and within the foramen actually they have a lot of spaces. Why? Because it give a lot of innervation to the hand, innervation to the lower part area. So they have to accumulate a lot of nerve fiber to this area. So they are actually little bit wide, little bit more compact in cervical area. And when actually travel a lot of nerve, they needs a lot of blood circulation also. So in the cervical area, they have a multiple blood circulation system that is arises from the vertebral artery, ascending cervical and deep cervical artery. And these artery are very close proximate to the spinal nerve. So they are traveling very close to the nerve. So most of the time actually our books, they give the evidence in the cervical epidural, because we know that in epidural space, especially in the cervical area, there is the 1.5 to 2 millimeter of spaces, and this is safe zone. But always think that epidural also is a very complicated things, especially in the cervical area, because there is a chance of a lot of LOR, false LOR, because here actually ligament of flavum are not continuous, are not compact, so you may find out the false LOR also in this area. Okay, so the vertebral arteries, ascending and deep cervical artery, they actually contribute this circulation system. Okay, so when actually we come through the foramen, especially the lateral foramen, so within the 2 millimeter of the travel or needle placing, you can find out the ascending cervical artery or the deep cervical artery to this area. Almost 20% cases we find out. If we see almost 1/3 of the patient, their feeding artery very closer to the spinal cord, and sometime if you correct your needle placement with ultrasonography very nicely with the use of the Doppler, sometimes you can also like injury to the nerve also, injury to the blood vessels. Like if you have injury to the feeding artery, sometimes it is spasm and it gives decrease the supply to the vertebral to the spinal cord. So when actually spinal cord are suffering of oxygen, they may be ischemia, their chance of ischemia. So it's a very much dangerous condition when actually you do this intervention over the patient. So already I have discussed like traditionally cervical, actually we do the fluoroscopic view, but here actually with the increasing of the expertness of the cervical facet ultrasound, cervical ultrasound, that actually we can see the few structure. Okay, we can see the blood vessels, we can see the nerve, so we have a very safe landing system. You know that when actually there is a very fog, especially in the winter season, the plane cannot actually land in the airport if the lighting system or the ground lighting is not properly actually exposed or visualized. So that time actually they have a very trouble when a very problem when actually they go for the landing. So the visibility is a very important question. So when actually increasing of the ultrasonography, uh, crystal ultrasonography, image ultrasonography system, they actually, we can see the tiny nerve, tiny blood vessels and the other things with the development of this ultrasonography. So we can very safe landing to this area, and we can give the injection and intervention to this area. So this is a very good things for our uh, like technique. Okay. So another one thing is the real-time injection. So when actually you go for the injection, even a little bit, very small amount of injection, like the 0.2, 0.3 or 0.5 ml, so that you also find out under the ultrasonography also. Okay. Now, when actually we scan these things, patient should be lateral decubitus in position, because we know that it is in lateral side, and we should use the high frequency linear probe, and patient neck should be little bit extended. Better to use, better to not use any kind of pillow under the head. So we can start by the two manner. So we can start in the scalene group of muscle. We know that in the scalene there is the traffic light system. So in the traffic light system, we can find out the three nerve. Okay. So one is the cervical 7, 6, and 5. So if you come little bit posterior from the scalene, you can find out there is the one elevation. This is the one elevation you can see. Suppose this is the, you can see there's the traffic line, traffic system. If you come little bit posterior, then you can see the only one elevation. So this elevation is the C7. Okay, why? Because in the C7 area, the especially the antitubercle are not so much finely defined. So you cannot actually differentiate this elevation, which is the antitubercle and which is the posterior tubercle, because it is very much rudimentary. The posterior tubercle is very prominent, but antitubercle is not prominent. But this is the C7 area. When actually little bit above, like 2 to 3 millimeter or 4 millimeter above, that time actually you can see the two elevation like this. So one is very big and there is a small. This is the posterior tubercle and this is the anterior tubercle. This big anterior tubercle is known as the Cassianus tubercle. This is the most defined tubercle you can find in ultrasound. Okay, and it is a very good landmark when actually you go for the intervention, especially in cervical facet, cervical median branch. Even any kind of intervention, it gives a very good landmark. Why? Because here actually you have to find out the which vertebra you have scanned. So this is the landmark. Cassianus tubercle is the landmark that gives the very good idea. So in the C6 area, there is the prominent anterior tubercle. This is known as the Cassianus tubercle. And in this area, you cannot see the vertebral artery. 90% cases of the vertebral artery that goes inside through the foramen transversum, and you cannot find out the with your Doppler. But if you come little bit down, there is the only one tubercle, posterior tubercle, and rudimentary anterior tubercle, and you can see the vertebral artery at this area, just anterior to the posterior tubercle. You can see there is the vertebral artery. You can see it is very exposed, and it's see very nicely with your ultrasonography, especially when actually use the Doppler system. If you come little bit above, like from C6, little bit above C5, so you can find out the double hem camel sign. Okay, so you can identify the two things. So anterior as well as the posterior tubercle. So both tubercle you can find out and you can see these things. Okay. So you can use the 22 gauge needle. So a little bit, so here actually we see, here you can see this is the very short area, and just in front this area, you can see there is the nerve, this is the nerve area. So just in front here, you can see the vertebral artery. Okay. When actually you give the Doppler, you can find out. Otherwise, if you not give the Doppler, so sometimes wall are black and white, so you cannot find out these things. If you see that little bit anterior, if you come, this is the C7. You can see this is the C7. So if you come little bit anterior, then you can see the traffic system, traffic light. Okay, you can see this area. Okay. This is the anterior scalene, this is the middle scalene. In between anterior scalene and middle scalene, you can see the series of nerve, you can see. So just if you little bit posterior, that you can find out the one elevation. This is the transverse process, especially the posterior tubercle. You can see there is rudimentary anterior tubercle, but you cannot find out. And here another things, there is the vertebral artery is exposed. Okay, these are the key point to find out, or key landmark to find out the cervical 7. When actually you come little bit anterior, little bit above, you can find out these very nice two elevations. So one is very big and there is little bit small. So big is the anterior tubercle, and this anterior tubercle is known as the Cassianus tubercle, and this is the posterior tubercle. If you come intervention to this area, so better to you have to come like this. So here actually it shows very closer to the nerve, but better to, you have, if you want to save landing, so better to come just to this area and stop this area. Okay. So when actually you stop, you can give the injection, it goes and it covers to this area. So if you come a little bit more, then you may injury to the few artery, ascending deep cervical artery. So you may hit or you may injury to this area. So always be caution about this. Okay. Now, another one things, what actually you should do, or you should actually always think when actually place your needle with the ultrasonography. Definitely, you should take a one image with the fluoroscopy. It should be the AP. Suppose patient in the lateral decubitus position. That time AP is the lateral view, true lateral view. So you have to take a lateral view and you give a very small amount of the dye, and dye should be spread like this. So this is a nerve root, so it should be like this. Okay. When the dye spreading like this, that time actually you give sorry. Actually, if the dye is spreading very nicely, and if it is not within the blood vessels, that time better to give the non-particulated steroid. Never go for the particulated steroid. Always give the non-particulated steroid, especially the dexamethasone. You can give the 5 or 10 milligram according to your desire. So usually we prepared the like a 2 ml of 1% lidocaine for diagnostic block. And if you go for the therapeutic block, you can plan for the 2 ml of the mixture, like a 1% lidocaine and the dexamethasone in 10 milligram, 8 to 10 milligram. Okay. So if we see the some literature or some publications regarding on the ultrasound. So first, actually, Galileo actually described this ultrasound guided cervical periradicular injection. That's been the selective nerve. Actually, it actually innervated, or it actually covered by, and it is discovered first by the Galileo. So after that, a lot of changes by the other physician, especially the Samin Naruz, because Samin Naruz is a very good uh, pain physician, especially in ultrasound. And we read a lot of books of Naruz they are published. And these books are very, very, very um, like new things they have give, and to give our idea and give our thinking. So actually, in his publications, he gives the idea, cervical nerve root injection ultrasonography. It should be give as a primary imaging tools, but always better to use the control system that should be the fluoroscopy. That's mean you should give the dye, and after giving the dye, you should look the spreading, either it is intravascular or not, or the spreading is the good or not. Because I saw a lot of time actually, when actually if you not giving that dye, sometimes it may within the fascia, within the muscle, or within the other structure. So sometimes your actually desired thinking is not justifiable. Okay. So if you see the another presentation, so actually they give like the needle should be like implanting technique, and it should be accurately placed at the area of the extraforaminal, but always never go inside the foramen. And definitely you should give the dye spreading. Always fluoroscopy dye spreading is very important. So another Dr. Lee, he's a very good and in ultrasound, and he gives a very good recommendation regarding these things. And in ultrasonography, most of the steroid injections significantly reduce the pain like 78% of the patient within the 3 months, and outcome is very good. But in our conclusion, what we actually conclude that use of the ultrasonography in OT setup, you should make ensure all the instrument for resuscitate you have to very close in your hand, and you should use the fluoroscopy when actually you do ultrasonography intervention. It should be very precaution when actually you do these things. Never ever only use the ultrasonography without having the pilot system or the control system like the fluoroscopy. Always use the dye, and this dye should be spread in a very good manner, and after that you have to go for the intervention. So if we see the recommendations, so we can see there is some recommendation. So interlaminar epidural steroid, it gives the weak, but transforaminal epidural free, preservative free dexamethasone, it gives the very weak. So recommendation is still now very weak, but if you do the ultrasonography, ultrasound guided injection, always should take help of the fluoroscopy. Okay. So another is the moderate. There is the pulse radio frequency of dorsal DRG and the radio frequency treatment of the DRG. So they are the weak. Okay. Now come to the another topics, that is the occipital neuralgia, and occipital neuralgia is very common things. If we see the International Headache Society definition, so occipital neuralgia is it's actually present with a sharp shooting stabbing type of pain in the occiput area. Especially it cover the occipital nerve. So there are the three occipital nerve. One is the greater occipital, lesser occipital, and the third occipital nerve. And most of the time actually it may associated with the radiating pain also. So it covered the temporal area, it covered the frontal area also, even if it covered the vertex area. But the origin of the pain, especially in the occiput area. If you press over the occiput area, so patient feel the pain at this area. So if you see the etiology, so trauma, tumor, infection, the post-surgical, even the post-radiofrequency, sometimes the subluxation, these are the most common. The occipital nerve, actually, if we see the three occipital nerves, so especially the most common is the greater occipital nerve. So greater occipital nerve is the part of the primary ramus of the C2, and it is a very important question for the MCQ. And when actually it emerge from this area, so it actually travel the suboccipital triangle. So when actually cross the suboccipital triangle, so after that it comes between the two muscles. These two muscles are the oblique capitalis inferior, and another is the semispinalis capitis muscle. So if you see the below muscle, it is the cervical two spinous process. So from here, the one muscle is like this. I will annotate the another color. So one muscle is like this. So this muscle is known as the semispinalis capitis. Okay. Sorry. This muscle is known as the oblique capitis inferior, and this is the another part of the oblique capitis inferior. So above this, the nerve is travel just below to the semispinalis capitis muscle. Okay. In between the two muscles. The above one, this is the semispinalis capitis muscle. The below one, this is known as the oblique capitis inferior. Oblique capitis inferior. So below one is known as the oblique capitis inferior. So when actually we do the ultrasonography, the oblique capitis inferior is seen like as the board. Okay, it's look as the board shape. Okay, so when actually nerve comes from the occipital suboccipital area to in between the two nerve, here is the one curvature. So here is chance of the impingement, and another when actually it come through within the semispinalis capitis. After that, when actually it very closer to the epineuritis and it comes to the vertex area, here is the chance of the another impingement or entrapment. So these two area actually main area for entrapment of the greater occipital nerve. Now come to the lesser occipital nerve. So if you see the lesser occipital nerve, usually the lesser occipital nerve is the branch of the superficial cervical plexus, which actually contribute the cervical 2 and cervical 3 area. So here actually lesser occipital nerve is very superficial, and it comes is the part of this area, and it comes very superficially, and it comes very closer to the unimportant muscle in our neck, that is the sternocleidomastoid muscle, just posterior or lateral to the sternocleidomastoid muscle. You can see it is very superficial to respect of the other occipital nerve. It is very superficial. Okay, so third occipital nerve. Already we have discussed third occipital nerve. It is the ascending branch of the dorsal rami of the C3, and actually it gives the own nerve supply to the facet joint. You can see this is the facet joint area. Actually, give the part gives the innervation of the cervical facet, and other part actually. Yeah. So it comes to the vertex area and gives the posterior part, supply the posterior part. So these are the main nerve for the occipit area. So what are the innervation actually where we need like the migraine, sometimes the tension type headache, cluster headache, chronic daily headache, hemicrania continua, sometimes the cervicogenic headache, post-traumatic headache, and the occipital neuralgia and trigeminal neuralgia. These are the common things. So recommended technique for USG, ultrasound guided greater occipital nerve. If we see, patient should be into the prone position. That's mean the head should be extended. When actually we start our scanning over the occipital area, especially the occipital protuberance, you can see all are black. Here is, you can see the thin line of the hyperechoic structure. This is actually the occiput. Under that, all are black. Okay, and it is very superficial. When actually you come little bit down, okay, when actually you come little bit down, here actually you can see this all are black. Little bit down, that time actually you can see the bifid spinous process. Okay, so little bit above, you can see the wall are black. When actually you come little bit down, like this area, you can see the bifid spinous process. This is the bifid spinous process. Okay, so when actually we find out the bifid spinous process, so that time actually we should change our probe direction. Okay, here actually probe direction like this. I will note it another color. Probe is like this, little bit like this. When actually find out that time, the lateral side of the probe, it should be turned towards the mastoid process. That's when it is like obliquely placed over this area. That time actually find out the one muscle. This one muscle is the inferior oblique muscle, and the another muscle, this is the semispinalis capitis muscle. In between, you can see there is the greater occipital nerve accompanied with the blood vessels. Okay. Okay, so this is the area for intervention of the greater occipital nerve. So how it should come? So this is the medial, and sorry, here actually, this is the medial and this is the lateral. So you have to come from lateral. Just you have to cross this semispinalis capitis muscle, and you have to stop and you give the injection to this area, and your job is done. Okay. So here actually we see in the first, you can see the nerve. So definitely if you see up and down, you can find out the vertebral artery very close to this area. It is lies in the medially and nerve lies in the lateral side. So you have to find out the semispinalis capitis. Underneath there is the greater occipital nerve. It is the greater occipital nerve. So it should be fine tuning your hand when actually scanning these things. Now come to the lesser occipital. So the lesser occipital, you can find out it should be very close to the semispinal scapulis muscle. So if you, spinal cleidocranial muscle. So if you see that the very superficial muscle and it is very thin at the occiput area is the trapezius muscle. And this is mainly into the posterior part. If you come little bit anterior, if you can see there is the semispinal scapulis, sternocleidomastoid muscle. In between there is the skin and fascia. So under that there is the one important muscle. This is the splenius capitis muscle. So above the splenius capitis and just posterior to the sternocleidomastoid muscle, you can see there is the tiny nerve. This is known as the lesser occipital nerve. Okay, this is the area for intervention. It is so superficial. So you can come like this, you can come like this, and you can give injection to this area. Just you have to find out the sternocleidomastoid muscle and the thin part of the trapezius muscle, and under the two muscle, you can find out the splenius capitis muscle. Over the splenius capitis muscle, you can find out the lesser occipital nerve. So third occipital nerve, already we have discussed. It is just over the second and third facet joint. So actually we have to find out according to the facet protocol. So if you go for the facet protocol, so you can find out there is the one important things. It should be the lateral cubitus position. So this is the one part of the cervical 2, and this is the part of the cervical 3. Okay, this is cervical 2 and this is cervical 3. This is the joint area. So this nerve is located very close to the joint area. Okay, within the 1 centimeter or within the 1 millimeter of this joint area. Okay, so you have to come into the in-plane technique or out of plane technique, and you give the intervention to this area. Before that, you, if need, then you can plan for the diagnostic block also. So usually this procedure we need to the 22 gauge 1.5 to 3.5 inch needle. It depends on your procedure, because in the lesser occipital nerve it needs only the 1.5 centimeter, but 1.5 inch. But in the the other area, you may need the 2.5 or 3.5 inch needle also. So drugs, usually we use the bupivacaine. We need the 4 ml of the bupivacaine. Now, including the 40 milligram of peptidine. So we can use for the diagnostic block, we can use the 0.5 ml to 1 cc, including the lignocaine and the particulate steroid. And if you go for the radio frequency, you can go for radio frequency. It should be conventional radio frequency, 80 degrees centigrade for 90 seconds. Now come to our last topics, the stellate ganglion block. Stellate ganglion is a very important part for the sympathetically mediated pain caring from the upper extremity as well as the head neck area. So sympathetic fiber actually all are immersed to this area, especially if we see the sympathetic ganglia to the cervical area, there are the 3 sympathetic ganglia. So one is the upper or superior, middle, and inferior cervical ganglia. So this cervical ganglia, especially the lower cervical ganglia, it actually fused with the cervical first thoracic. This is the lower cervical, and it should be merged with the first thoracic. When actually it merged with the first thoracic, and it produce the big star shape ganglia is known as the stellate ganglia. Okay, so stellate ganglia is formed by the 2 things. Okay, so one is the inferior cervical and there is the first thoracic ganglia, and actually it lies just within the paravertebral fossa and the medial and the posterior. And if you see the medial and the posterior to the carotid artery, and we know that it is a very big star-shaped ganglia. So the length is around 2.5 to 2 to 2.5 centimeter, and the width like 1 centimeter is wide. And most commonly, we can find out just anterior to the cachinous tubercle. But if we see, its length is 2.5 centimeters. So it cover both cervical 6 little bit and just inferior to the cervical 7. So most of the cover the cervical 7 area. But here actually we cannot give injection under ultrasonography. Why? Because the vertebral artery is exposed to this area. So better to calm this area when actually where actually vertebral artery already go inside the foramen transversum of the cervical 6 area. Okay. So if you give injection within the fascia, just under the fascia, it actually spreading up and down. Okay. When actually it goes up and down, it covers the full length of the stellate part. So indication, if you see the indication, so mostly painful indication like the sympathetically mediated pain from the upper extremity, head, neck. It comes from the like herpes or the post herpes neuralgia, like the phantom limb pain, cluster headache, especially atypical vascular headache. If there is the atypical vascular headache, intractable angina pectoris, so we can go for the painful condition. Also, we can go for the non-painful condition like the vascular changes, Raynaud's phenomenon, obliteration of the vascular disease due to the vasospasm, then the hyperhidrosis, lymphedema, then the refractory ventricular arrhythmia, and the post-traumatic stress disorder. So these are the most common actually intervention area. We can give intervention to this area. So scanning protocol, there is the 3 scanning protocol, how actually you can find out this part. So first is scanning 1. So here actually we have to find out the cervical 6, and in the cervical 6 we know that the anterior tubercle is most prominent. These anterior tubercle are very prominent anterior tubercle. You can find out that this is the prominent anterior tubercle. If you find out the prominent anterior tubercle, then you can find out the some other things like from the skin. Under that there is the semi-spinal sternocleidomastoid muscle. So under that you can find out the one very important muscle for this area. This is the longus colli muscle. And if you come little bit anterior to the longus colli muscle, you can see the carotid artery. And if you give the Doppler, you can see very sharp color it takes. Okay, so after that you can see the another muscle. You can find out this is actually the uh, longus capitis muscle. This is the this is the longus capitis muscle. This is the longus colli muscle. Okay, so you can find out with your ultrasonography. And the middle part, you can see the thyroid muscle. So previously, actually, we do the out of plane technique like this area, and you have to calm this area, and you need to keep this area because it's the unseen process. Okay, you can see. So here actually you come and you can get the injection little bit above. But right now, actually, we do under ultrasonography because we can see a lot of structure here. So better to come like this area, and you have to give the injection under this fascia area. So here is the prevertebral fascia. You can see. Okay. This is the one technique. This is the another technique. You have to know. This is the technique 2. Here actually you can find out the cervical 7. How can you find out the cervical 7? Because there is the absence of the cervical in the cervical area. This is the anterior tubercle. And you can find out another very important thing, that is the vertebral artery. So you can find out the, so this is the carotid artery, and this is the vertebral artery. You can find out. So you can find out the vertebral artery because it is already exposed in the cervical 7 area. When actually you come little bit above in the cervical 6 area, or this vertebral artery go inside the foramen transversum, and it actually it is covered by the foramen transversum. Okay, so now come give the Doppler to this area, vertebral area, and you can find out these things. Okay. There is another technique. This is at the cervical 6 area, when actually you scanning before going to the intervention. When actually you come little bit at the area of the C6 level, perform the scanning without color. So that time actually you find out the one elevation or one swelling structure. So here actually you can if you see that. This is the thyroid, and here is the one swelling structure. This is actually the esophagus. Okay, above that, this is the paravertebral fascia. So you can see this. So above this area, you can also give the injection to this area. But you can find out with this the first two technique. This is very convenient, especially the first one, when actually you find out the Cashier's tubercle in the C6 level. So already I have give the information. So you can come bilateral. So you can come out of plane technique to this area, and you can also come to the lateral to medial technique when actually you cross through these few muscles, especially the longest capitis and longest colli muscle. And it is just you can see that your needle tip should be in between the prevertebral fascia and within the longest colli and longest capitis muscles. This is the prevertebral fascia. So you have to cross the prevertebral fascia, and you have to come just anterior to the longest colli and longest capitis muscle. So just above this, there is this very big shape of the muscle. This is the stellate ganglia. Okay, so out of plane technique you can give, but sometimes actually it injury to the thyroid, and sometimes it also injury to the associated nerve also, like vagus nerve and the phrenic nerve also come through this area, travel through this area. Okay, so in cervical area, always better to visualize with the Doppler, because a lot of structure is there and a lot of important things is there. So now come to the clinical part, and it is very important for your intervention. Better to always give some small amount of the saline before giving any kind of lignocaine or other things in plain technique. When actually you're holding your needle in between the fascia and the longus colli muscle. So after that, always better to turn your head to the opposite side. That gives actually the carotid artery little bit anterior, anterior and far away from the cervical 6 area. So it gives the little bit space rather than the normal conventional technique. So it's help to place your needle in the correct position. Then when actually we landmark this area, always scanning the cephalic and caudal direction, also C6, C7 area, because either you are in the right position or not, you have to actually sure. And 7 to 10% patient of the vertebral artery, they are exposed in C6 area also. This is very important and dangerous things, because cervical artery is a main component of the circle of Willis, main blood circulation system of the cerebral area. So never disturb the cervical artery, never, ever. And after that, you can give the Doppler, and you have to actually find out the vertebral artery and other carotid artery and other small artery also, and give the hydrodissection small amount of the normal saline. When actually you give the small amount of the normal saline, you can dissect this area, and after that you have to give the local anesthesia, because sometimes the small amount of the local anesthesia, if you go intravenously, it may actually seizure to the patient, and patient may die within the few minutes also. And always better to avoid bilateral injection. It should be go for the one unilateral injection, especially in the if you go for the unilateral injection, it actually you can avoid the respiratory complication. But if you go for the bilateral injection, if it paralyzes the phrenic nerve, so difficulty to respiratory system to continue. So always better to avoid bilaterally. And another is patient should be in AWK, not given to any kind of sedative substance like the propofol or fentanyl or other things. And always patient should be give the awareness about the Horner symptoms, because we know that Horner symptoms is a positive things to the patient. Actually, your nerve blocks successfully done at this area. So other than Horner symptoms, the conjunctival flashing, upper extremity numbness, weakness, and hoarseness, so dysphagia, it may happen to this area also. Okay, so if we see the what are the chemical and the thermal actually lesion we can do. So we can go for the chemical lesion. So usually we use the phenol, but there is some complication also there. So always precaution before going to the phenol. Conventional thermal radio frequency. So we can go for the thermal radio frequency, and the pulse radio frequency we can also, but it is less damage to the nerve, but the duration of also is very less. Okay, so if we see the recommendations, so in the herpes zoster and the post-herpetic neuralgia, we can go for the stellate ganglion block, but it is still now weak. If we go for the CRPS, stellate ganglion block, it gives the level 3 of evidence. So thank you for patience hearing. If there is any questions, I will try to answer it. Okay, Dr. Javed.
Yes, Dr. Milton, it was a wonderful presentation and extensive presentation on the cervical spine pathologies as well as interventions. Everything was very clearly covered by Dr. Milton. I thank you for the wonderful presentation. So now we'll be moving on to the questions. So I'll request the participants to message their questions in the chat box, which we can ask our faculty for today, Dr. Milton. So Dr. Milton, there is one question which is there. What they are asking is it possible to do RFA, pulsed or conventional to the stellate ganglion block? What is the safety and concerns?
So we can go for the pulse radio frequency, and we can go also the thermal radio frequency. So both are you can go, but important things is your needle placement. Because you know that a very important structure surrounding on it. Suppose you will go for the thermal radio frequency. So what happens? We know that the thermal radio frequency, there is the heat generation. So in the thermal radio frequency, we actually, if we set like the 70 to 80 or 90 degrees centigrade temperature, so there is the heat production. So in very close proximity, there is the important tiny nerve like the phrenic nerve and the other important nerves. So it may actually like destroy also. So if you go for the safe planning, so better to go for the pulse radio frequency. So before that, you actually go for the one important things, that is actually the diagnostic block. After that, you have to go for the steroid injection to reduce the sympathetically mediated pain. If it is successfully work, then you can plan for the third intervention like the stellate ganglion radio frequency or the thermal or the chemical. So better go for the now most of the actually literature and things, they are more give to the radio frequency, especially the pulse radio frequency, but you can also go for the thermal radio frequency, and it should be within the 70 degrees, around 70 degrees temperature. It should be maintained this 70-degree temperature, and always precaution your needle, because if it is in outside to this area, here actually one important things, because if you go for the only the radio frequency, so that time actually your needle should be placed in the cervical 7 or cervical 7 area, because in the cervical 6 most of the stellate ganglion are not covered in the cervical 6 area. So it is covered in the only the cervical 7 area. And you know that it is a very big ganglia, like it is like a 2.5 centimeter in length. So if you cover, because we know that our actually the tip of the thermal radio frequency, it cover only the 4 to 6 millimeter, not more than. So most of the time actually it not cover all of the part of the radio frequency, all of the part of the state ganglion. So still now more favor on the chemical, but you can do the thermal or pulse also, but better to go like these things. Go for the diagnostic block, after that go for the steroid injection to reduce the pain for the certain period, because sympathetically mediated pain sometimes if you break down the brain cycle, so sometimes it may patient have a very good feeling after actually cessation of the pain cycle and the other things. So this is the very good things you can plan according to your step by step.
I think very true and well explained. So one more thing is where there's a doubt that the IJV comes in the way of the trajectory of the stellate ganglion block. So any clinical pearls on how to navigate that part, Dr. Milton?
Uh, Javed, actually, I cannot understand your question. When actually we go for?
No, no. One of them has message that an observation with the respect to the slide you had put, internal jugular vein comes in the way of the pathway for the
Oh,
uh,
sure, sure, sure,
ganglion block.
sure,
Yeah, that one.
sure. Actually, internal jugular vein is sometimes comes in our way, but one things, if you give more pressure, so internal jugular vein are collapsed. Okay, so better to use the light pressure to this area. Patient neck should be turned to the opposite side. These two things. So one is the patient neck should be the turned to the opposite side. Another thing, your probe should be hanging over the just over the neck area. Should not keep more pressure to this area. What happens if you give the more pressure? Then actually you cannot see the internal jugular vein. What is the site? What is the area? So when actually you give the very light pressure to this area, that time when actually you navigate your needle through in plane technique, that time actually you can avoid with the change of your bevel direction. So here is the bevel direction is very important. We know that in our bevel, there is the tip and another is the flat surface. There is the area. So better to when actually you have to travel your needle, that time the bevel area should be very close to the internal jugular vein and your tip should be just opposite to the bevel area, and you should just traveling and you should cross the internal jugular vein. After that you have to change, or after that you have to actually navigate your needle direction to the specific area, especially when actually you comes to the like longus colli or the paravertebral fascia area. That time actually you have to change your needle direction and other things. So what I feel that needle direction, especially the um bevel and the tip, it should be manipulated when actually you travel through this internal jugular area, and always give very less pressure to the internal jugular vein. That gives the very good benefit to visualize to this area. And patient head should be the turn opposite side. These three things, if you have planning and you have use in your technique, that gives a very good benefit and avoid the injury to the important structure.
Very true. I think well explained. Another question which is there is how to do isolated lesser occipital nerve or greater auricular nerve block. Both are superficial and nearer to the sternocleidomastoid muscle.
Yes, actually, auricular nerve, it is very it's not very closer to the occipital area. I will try to share a one picture. Just give me 1 minute. That gives a
Okay.
very
Uh, yeah, you can try sharing now, Dr. Milton. Yes.
so here actually you can differentiate two things. Okay, so in this area the sternocleidomastoid muscle are very big, but when in the we come to the lesser occipital area, it is very close like this over this area. Okay, where actually two muscle, especially the trapezius muscle and the sternocleidomastoid muscle, both are very thin. But when actually come just below to the ear, you can find out the big sternocleidomastoid muscle. Okay, over the sternocleidomastoid muscle, you can find out the greater auricular nerve. Okay, so area is different. So here it is just under the ear position, and it is just over the sternocleidomastoid muscle, especially the big bulk area. You can see the very big bulk muscle, sternocleidomastoid muscle. So above that, you can see the you can find out the greater auricular nerve accompanied with the blood vessels. And if you see the lesser occipital, so it is not very close to it. It is the another side. You can see this is this picture is not so good. If I actually add this one, that is better for understanding.
Yes.
So here you can see very very thin layer of sternocleidomastoid muscle, and it is very close to this area. And when actually you search the greater auricular, this is close near to this area. This is actually the area. And here you can see this is the one important muscle, trapezius. Is the very thin layer. This is the very thin layer. Just lateral to it, you can find out. But in the auricular, there is the big sternocleidomastoid muscle. Above it, you can find out the greater auricular nerve. And it should be just middle of the neck. Okay.
Yes, correct. I think that was well explained as well as differentiated between the two nerves. Next question, Dr. Milton, is what intervention would you do in post-herpetic neuralgia of the face? Because you've mentioned stellate ganglion block has got weak evidence.
So still now it is weak, but still we do these things because
Correct.
what actually happened in herpes, post-herpetic neuralgia, this is a very important message should be asked. In post-herpetic neuralgia, most of the intervention are less recommended or less actually give the positive benefit. Why? Because the when actually patient suffering with the herpes, most of the time the nerve is already damaged. And what intervention we do in our daily practice, most of the intervention, their recommendation is weak. Most of the recommendation. If we see the recommendation, that time actually we can
Okay.
find out the one important thing, that is the acute in acute position you have to go for the intervention. Like in acute stage, like a patient is suffering for the 1 or 2 week, patient have a suffering from the pain and other things, that time actually we go for the intervention, and this gives a very good outcome rather than the any other like intervention. Okay, so you can go for the steroid, you can go for the other like mostly the steroid is the most commonly used still now. Or if it's a patient is suffering from the cervical any nerve root related, that time actually you can go for the cervical epidural, or sometimes you can go for the dorsal rami block. But these all things actually give the less benefit when actually patient already suffered with the post-herpetic neuralgia. Okay, so in the post-herpetic neuralgia, if you see the most of the recommendation, they give actually the negative or less recommendation to the patient. Only the few recommendation that actually give the best idea, and most of the recommendation they should be used in the acute phases, not in the chronic phases. Suppose if you give for the go for the like epidural injection, and it give the more benefit in the acute stages, not in the chronic stages. So in the chronic stages, So most of the time you can plan in phase you can plan only for the stellate ganglion block. Still, it is less recommended, but only that these things is the best possibility. Even most of the time, what we plan, like the spinal cord stimulator. Suppose in not this area, I am talking about the generalized. So spinal cord stimulator, they give the very good evidence, but in herpes zoster, it gives only the very weak evidence to this area. So uh,
So,
actually, it's
yeah.
really very like a shorten of our intervention that. But still now, still at ganglion, it gives the weak recommendation, and this weak recommendation is still approved by our pain physician and by our pain society, and it is more appropriate rather than the any other intervention. But if it is in the nerve root related problem, then then you can plan for the pulse radio frequency of the dorsal root ganglia. That gives the little bit more evidence rather than the straight ganglion. If it is related to the only the nerve root, if it is not related to the nerve root, that time actually you cannot plan for this. Will sphenopalatine ganglion block helps her? No, actually sphenopalatine. আচ্ছা, আচ্ছা, আচ্ছা। So sphenopalatine block also you can plan for the it gives the it not gives the so much evidence to this because it is covered only the this head neck area, but if it is covered the faces area, so it is very difficult to cover this area. What gives evidence sphenopalatine, Dr. Javed, actually?
Yeah. No, I think very true because post-herpetic neuralgia, as with any chronic neuropathic pain conditions, interventions have a very limited role. It's more of the multimodal management protocols which have to be followed. And it is a very difficult condition to treat. And especially if, as Dr. Milton was mentioning, apart from the face, if it is there in other structures also, the one with a little better evidence is the DRG, the DRG pulsed RF, right? Dorsal root ganglion stimulation, the spinal cord stimulation, all of these, have a little better thing. But again, it's multimodal, multidisciplinary approach is what is going to help. So I think even the next question, Dr. Milton, the whether sphenopalatine ganglion block will help or not, I think it is, we have answered that question previously, that interventions itself don't have much of a role in patients with chronic neuropathic pain conditions. So recording will be provided. We will be there in our Algos Academy YouTube channel. So before we, I think there are no more questions mentioned in the chat box. So before we come to a conclusion, I'll just want to share an update from my side. I'll just share my screen. Hope my screen is visible. So we have our Algos Academy ultrasound hands-on workshop coming up next Sunday on the 1st of December at Bangalore. And basically, this comes as the second installment. Previously, we had conducted a successful workshop in the month of April in the same year. We had our focus was on the module of upper limb. So our focus was on shoulder, elbow, and wrist in this first module. We had faculty demonstrations, volunteer scanning, and also live interventions as well as you can. So this time our focus is going to be on spine, right? So all cervical, thoracic, lumbar, and sacral spine. Along with faculty demonstration, we go into volunteer scan stations in the procedures as well. Okay. These are all the structures and everything which we will be uh, demonstrating along with the RF and cryoablation needle points. So that was the update. So I think we are coming towards the end. I'd like to really thank Dr. Milton that, it was a wonderful presentation, very comprehensive in that because I needed somebody who can take care of this region, cervical spine, and he has wonderfully done that. He has demonstrated, he has told each and everything. I think no need to read any book on cervical spine ultrasound. If you just see this presentation, I think it will be more than sufficient by Dr. Milton. It was a wonderful talk, and I think he's answered all the questions as well. Again, heartfelt thanks to Dr. Anamul Haq Milton So I'm very happy that he agreed to do this webinar at a short notice also. So very, very happy to have you over here, and looking forward to host you soon in Bangalore as well when you come, inshallah.
Sure. Thank you, dear friend and brother, Dr. Javed, for inviting me. And if there is any question, so you can, anyone can inform us, Dr. Javed or me. We'll try to answer you, and we will try to make you happy with our answer. Thank you. Thank you, Dr. Javed, for your elevating the pain, especially the workshop and free webinar. And what I can remember in my uh, planning, that in during the COVID situation, that time actually I started one free webinar. That time actually you are the first presenter that times, actually I can remember. And we almost we did like more than 15 webinar during the COVID time. So great time that times. Actually, we are connected over the internet and over the Zoom. So thank you all the participant. Thank you for patient sharing, and thank you also Dr. Javed for inviting me and give this opportunity to talk something over the fellows. Thank you.
Thank you so much. Thank you all the audience as well. You've been very patient and kind, and to listen to all of us. And we'll look forward to come back next month soon with another free webinar series, right? And yeah. And before I end, the webinar video will be uploaded on the Algos Academy YouTube channel for free, of course. I will update you all as well as soon as the recording is available. Thank you very much. Have a great day ahead. Good morning.